the least common is Bell's palsy. So over 90% of women with epilepsy have a normal pregnancy. That's something very reassuring. Epilepsy affects approximately 0.5 to 1% of the general population. The risk of a seizure disorder is greater among the children of mothers with epilepsy. These are facts that we know about epilepsy and pregnancy. Whereas 2 to 3-fold risk of perinatal mortality has been reported in infants born to women with epilepsy compared with control. So we know that there is an effect, but how big the effect is not that big, not that we as the impact that we imagine. Major and minor malformations, how much is the percentage in the general population? How much in the general population? Do you know? 2 to 3%. Okay? In epileptic moms taking anti-epileptic medication, it's 2 to 3-fold that. So it goes from 4 to 6%. Okay? So it's not that high. When we say that teratogenic effect of the anti-epileptic medication is high and the mother has to reduce her medication and we're worried about malformations in the baby, you would be thinking about something that is 20, 30, 40%, right? It's only 4 to 6%, okay? So the impact is not that large, but the worry is still there. So when are the times that we have to counsel the patients, or we have to sit with the patients and tackle things more, or start in the management of these epileptic patients? Usually we start preconceptionally, right? What are the areas that we have to tackle in the preconception time? Yes?
Some drugs are teratogenic, so we might need to switch some of them.
Exactly, and that should all be done preconception. Right, what else? Anything else?
I think we need to give them more calcium, or we'll use electrolyte or shunt, because after that,
Folic acid. Folic acid. So we have to give them high-dose folic acid at least 3 months preconception. Do they need to plan their pregnancies? Okay, so we agree that they need to plan their pregnancies. How can they plan their pregnancies? They need contraception, right? Can they take any contraceptive method? They can use any contraceptive method with the same accuracy and same efficiency as anybody else. Why?
They may miss some.
I think, or,
Yes. So there are some anti-epileptic medications that are enzyme inducers. So if they're metabolized in the liver, and they are enzyme inducers. So oral contraceptive pills, and the combined oral contraceptive pills are also metabolized in the liver. And if there are enzyme inducers, they will be metabolized quicker. So they won't be as efficient. So we usually tell them to be very regular on their medication. Maybe they need to double the dose of the oral birth control pills, or they need to use other methods of birth control in certain times, like when they're taking antibiotics when the efficiency of the oral contraceptive pills aren't so good. Okay, clear? So we tell them that they need to be on contraception, good contraception, to plan their pregnancy, lessen the dosage of anti-epileptic drugs, or put them on the most efficient, lower dose and the less teratogenic medication before they plan pregnancy, and folic acid. So when can we alter their medication? Of course, it's not us, it's the neurologist that alters the medication. But when are they allowed to alter the medication? Patient that has frequent seizure attacks. Every 2-3 months she has a seizure attack. Can you alter her medication? Well, you might need to alter her medication and increase her medication, not actually reduce the number of medication or the dose that she's taking, right? Okay, so what or reducing the medication for epileptic mom. Yes. Yes. How long does she have to be? To get pregnant, she needs to be seizure-free for 6 months. So to give her the green light to get pregnant, she has to be on the same medication for 6 months without seizures to say that, okay, you can get pregnant safely. But to alter medication, to reduce the number, some patients are on 2 or 3 medications. To alter the number of medication or to reduce the doses of the medication, she needs to be seizure-free for 2 years. Clear? Okay? 2 years seizure-free to alter the medication, to lower the dose or remove a number of medication. And to allow her to get pregnant, she has to be seizure-free for 6 months. Clear? So patients, women of childbearing years should be counseled regarding the interactions between anti-epileptic drugs and oral contraceptive therapy and the potential risks associated with epilepsy and pregnancy. Patients who have been seizure-free for 2 or more years should be considered for anti-epileptic drug withdrawal 6 months or more prior to a planned pregnancy. Patients planning pregnancy should be managed on the most effective anti-epileptic drug for their seizures except valproate. Why valproate? Yes. It's the most teratogenic, and the problem with valproate. So, what are the teratogenic effects of anti-epileptic drugs that you know of? That we give folic acid to reduce the teratogenic effect. But what are the teratogenic? What are the abnormalities that you can see in a woman taking anti-epileptic drugs?
I think missed limbs.
Neural tube defect.
Neural tube defects. Excellent. What else?
No limbs, I think.
Cardiac defects, and the most complex cardiac defects come with valproic acid. Okay, that's why we try to keep the most away from valproic acid. But if the patient is on it and she got pregnant, so she has the risk of having. What else? What other abnormalities can happen?
High drops.
No, not really. So in neural tube cleft lip, clefts can happen. Facial dysmorphisms, facial abnormalities. These are the most common abnormalities. So preconception, we try to keep the patient on monotherapy, 1 medication, and the lowest possible drug dose to limit the risk of teratogenicity. The anti-epileptic drug regimen should be optimized 6 months prior to planned conception. What do we mean by optimized? So she's seizure-free for 6 months on the same dose of medication. Folic acid should be initiated 3 months before a planned conception, and it should be the 5 milligram, the high dose of folic acid. So this is preconception. Now, knowing all of the risks of epilepsy, and the major risk is teratogenicity. Other risks, what are the other risks? In pregnancy, what can other risks, what do you think can happen to a mom?
She can get a seizure and
She can get a
lose
seizure, yes.
control, hit her tummy.
She'll get traumatized.
Yes.
The fetus will get traumatized. Also, what happens to a mom when she gets seizures?
She loses muscle, I think.
What happens to a mom when she gets seizures?
She might have involuntary contractions. She might get she might hit.
Preterm birth, trauma. What else? Do they get hypoxic?
Yes.
Okay. If the mom gets hypoxic, what happens to the fetus? Also gets hypoxic. Okay. So all of these are effects that can happen during pregnancy. So what is more severe? Getting a seizure or the teratogenic effects of the pregnancy, of the medication?
Getting a seizure.
Getting a seizure.
We said that it's 4 to 6%, صح? And if she has a seizure, all of this can happen. So what is more traumatic?
I think getting a seizure.
The seizures.
Very
Okay. The seizure effect is more. That's why we have to optimize the medication before she gets pregnant. And if she gets pregnant, even if it's on teratogenic medication, then she continues the pregnancy without altering the medication. So she's on, yes,
But in the seizures, won't it be only like something temporary, but the teratogenic, it's more on a
yes,
long term?
temporary. If the mom gets hypoxic
Temporary.
and the fetus gets hypoxic,
Temporary.
what was the cause? Brain damage in utero. Okay? Yes?
I think he means it in a way like that the seizure lasts, for example, for a minute.
Yes.
So in this case, we won't have that much of.
If a patient's on regular medication, she's on 3 medications, they could barely control her seizures. One of the medications are teratogenic and valproic acid. If she takes it, there's almost a 10%. The highest it can get a 10% risk of teratogenicity. If she takes these medications, she's worried about the fetus and she stops taking it suddenly. Can she go to status epilepticus?
Yes.
Will this kill the mom?
Yes.
Okay? Understand what I mean? When we balance medicine, this is how we balance it. Okay? The less risk to the higher risk. Okay? So we do not make any changes to anti-epileptic drug regimen for the purpose of reducing teratogenic risk in an established pregnancy. She comes to you, she got pregnant, she's on medication, you keep her on this medication until her seizures are controlled. Okay? What can increase the seizure activity during pregnancy?
Stress.
Stress of the pregnancy, stress of being worried about the teratogenic effect of her medication. What else?
Trauma.
What happens in pregnancy physiologically?
Hormonal
Hormonal
levels.
levels.
طيب, what can it cause to increase the seizure effects? Is there any worry about compliance of her medication? Any worry? Would you be worried? After she comes, the first counseling in the clinic in early pregnancy, you tell her that you have a risk of this baby having abnormalities in the heart, abnormalities in the face, in the neural tube. You don't know what's happening to your fetus. Would you worry about her being compliant on her medication the next day to actually taking her medication? So being worried about the pregnancy might make her less compliant to her medication, and she might, it might increase her seizure activity. What else? Also has to do with compliance. Effects of pregnancy. What happens in early pregnancy?
nausea, vomiting.
Yes. Okay. What will happen? So she can't take her. So after she takes her medication, half an hour later, she has nausea and vomiting. Okay, so that might reduce the compliance of the medication and then affect her seizure activity. Okay, what else? Worry, stress, being sleep deprived, okay, not eating well can also trigger seizures. Mid-pregnancy, what is physiological event in mid-pregnancy happens that can cause increase in seizure activity? What happens to your blood volume? To a pregnant woman's blood volume? 50% increase, صح? What will happen to the concentration of the medication in her blood? It will reduce, صح? And that can increase the seizure activity. So what do we have to do antenatally?
Increase the dose.
We have to monitor the dose in every trimester because the physiology in each trimester is different. Okay? What else can increase the seizure activity? Later on in pregnancy, it can be sleep deprivation, like I said, increasing the plasma volume. All of these can affect the dosage of, so antenatally, what do we have to do for the patient? First of all, we said that we don't alter her medication. In fact, we monitor the medication, the doses in each trimester to make sure that she's on the optimal doses. There are some medications that we can monitor the level in the blood, and there are other medications that we just go with the symptoms of the patient. What else? Because of the teratogenic effect, what do we do antenatally? How do we monitor antenatally?
Ultrasound.
We check by ultrasound if she has abnormalities in the fetus. Okay, so when do we check by ultrasound? When is the earliest we can check by ultrasound? If she has a neurotube defect, if the baby has a cardiac anomaly, when? First trimester, at the MT scan, صح? This MT can be the first sign of a neurotube defect, cardiac defect, clear? And then the second time that we check also, so MT is normal, everything is fine. Are we out of the woods? Khalas, it's okay? No, still. When do we do another scan? Anatomy scan at 20 to 22 weeks. What do we check for? From head to toe. We check for the cleft, we check for the facial dysmorphism. Facial dysmorphism, the problem with it can't be seen by ultrasound, even by 3D and 4D ultrasound. It's not necessarily something that we can see. Okay, so what we do check for is cleft. We can check for cardiac abnormality, neural tube defects. Some patients with that are on multiple medication, there's something called anti-epileptic drug syndrome, and it can cause IUGR and nail and skin abnormalities and facial abnormalities. And this you can see it in the third trimester. Also, what is indicated in a patient that is on anti-epileptic drugs? Another ultrasound that we have to do for them. Specific ultrasound. Fetal echo. Okay, fetal echo to rule out any cardiac abnormalities. So we do not make changes to anti-epileptic drug regimen for the purpose of reducing teratogenic risk in established pregnancy. Women who experience increased seizure frequency are sleep deprived, non-compliant because of concerns about the effects of the medication on the developing fetus. Altered anti-epileptic drug pharmacokinetics may also contribute to change in seizure frequency during pregnancy, and seizures are believed to be harmful to the fetus, causing fetal bradycardia. So hypoxia. Later on in pregnancy, so early in pregnancy, the hypoxia, the trauma can cause miscarriage, okay? Mid-pregnancy also, it can cause miscarriage or it can cause trauma. Later in pregnancy, it can cause hypoxia, bradycardia, intrauterine fetal death. Trauma can cause abruptio placenta. All of these effects can be due to the seizure activity, okay? What do? We monitor both total and fetal and free plasma anti-epileptic drug levels. These are the drugs that we can monitor in blood during the pregnancy, at least once each trimester, and again in the first or second week postpartum. Prenatal screening for congenital malformations, like I said, the nuchal translucency screening, and then the anatomy scan, and then the fetal echo. Most common abnormalities, like we said, neurotube defects, facial clefts, and cardiac defects. Anti-epileptic drug syndrome includes developmental delay, nail hypoplasia, growth restriction, and mid-phase hypoplasia. This abnormality, the mid-phase hypoplasia and the facial dysmorphism, is something we cannot see until after delivery, so we don't discover this. So usually when we do counsel a patient, we say, okay, so anatomy scan, MT scan is normal. We can only reassure you 90 to 95%. We cannot reassure you 100% until you see the baby after delivery, because facial dysmorphism cannot be seen by ultrasound. Okay, so the mom is not reassured until after delivery. What obstetrical complications can happen? There are usually association, but it can happen according to the symptoms or the frequency of the seizures of the patient. It includes low birth weight, lower APGAR scores, preeclampsia is an association. Also bleeding, of course, when you think about the patient going through trauma, if she has a lot of seizures, placental abruption, and prematurity. Labor and delivery are not usually associated with increased seizure frequency or complications. Postpartum. Can anything induce seizures postpartum? Yes, she's sleep deprived, she's stressed, she's tired. What else? Also the physiology of that time, also with the monitoring of the doses of the medication also needs to be monitored. The postpartum period, we usually advise patients to be accompanied by somebody while taking care of the baby, so that there's no risk on the mom or the baby. We are usually worried about the mom having a seizure or having any event during while she's taking care of the baby. Okay, so we usually ask for at least for the first 2 weeks to have somebody accompany her with the baby. According to the medication, can she take the medication and breastfeed? Okay. Most medications she can take. Okay. The only medications are the sedatives like benzodiazepine. If she's taking them, we're only worried about the baby getting tolerant or taking the medication. Usually, what we do ask any mom taking any medication during breastfeeding is to keep a 4-hour timeline between the breastfeeding and the medication. Yani, what we tell her usually is to breastfeed the baby, take her medication, wait for 4 hours, and then breastfeed again. Okay? Just to make sure that no medication goes with breast milk to the baby. Any questions about epilepsy age?
Doesn't this decrease the amount of breastfeeding for the baby?
Yeah, but it's better than giving the baby drugs. Huh? It's only the benzos. The rest of the medication is fine. Okay. Multiple sclerosis. You probably know about multiple sclerosis more than me, but we're just gonna be talking about its effect on pregnancy and the effect of pregnancy on it. It is an immune-mediated demyelinating disease of the CNS, typically characterized by relapses and remissions of neurological deficits. MS occurs with a 3-to-2 ratio of females to males and a peak incidence of 30 years of age. So it's mainly seen in the reproductive age of women. Okay? During an MS exacerbation or a relapse, patients typically complain of a progressive neurologic deficit developing over several days. Common symptoms of an exacerbation include those associated with optic neuritis, decreased visual acuity, and one eye or ocular pain, and or asymmetric numbness, weakness, or ataxia. Pain is rarely a symptom of MS flare, but it can be a long-term effect of chronic MS. There are no recommendations for or against pregnancy in women with MS. So, women with MS have variable disease. Okay, there are patients that are completely normal; they hardly have any effect of the disease, and there are some women that are wheelchair bound from the disease. Okay, so does pregnancy affect these women? Usually, pregnancy is associated with a significant decrease in MS disease activity. So this is usually pregnancy is relieving to their symptoms. It reduces the activity of their disease. The postpartum period is associated with increase in MS activity, and usually if the neurologist is going to start medication, they start it in the immediate postpartum period to reduce the relapses in the postpartum period. MS itself is not a contraindication to breastfeeding. However, the medication should be taken into account. Effect of MS on pregnancy. Maternal MS is associated with an increased risk rate of cesarean delivery, lower infant birth weights compared with women without MS. Usually the effect of MS on the pregnancy is very minimal. Okay? Any questions about MS? طيب, going to myasthenia gravis. Myasthenia gravis is an autoimmune disorder resulting from abnormal T cell regulation and the production of antibodies against the acetylcholine receptor on the neuromuscular end plate of skeletal muscle. Affected patients are often young women who usually present with fatigable weakness after repetitive muscle use. Pregnancy has a variable effect on the course of myasthenia gravis. The first trimester and the acute postpartum periods are times of highest risk for exacerbation. Like MS, the postpartum period, but in myasthenia gravis, the first trimester is also a time that exacerbation can also occur. Even in MS, usually if exacerbation happens, it happens in the first trimester and in the postpartum, the early postpartum period. Anticholinesterase agents such as pyridostigmine are the standard first-line treatment for myasthenia gravis, like in the non-pregnant population. Dose adjustment may be required in pregnancy. Glucocorticoids, azathioprine, and cyclosporine may be used if anticholinesterases fail to control myasthenia gravis exacerbations. Magnesium sulfate is contraindicated in patients who have myasthenia gravis, since it can precipitate a severe myasthenic crisis, and this is something we really have to stress on, that patients with myasthenia gravis, even if they go into an eclamptic fit, you cannot give them magnesium sulfate, okay? Severe hypertension can be treated with methyl dopa or hydralazine, while beta blockers and calcium channel blockers should be avoided if possible. The second stage of labor may be affected. Theoretically, it's not usually really affected, but when you think of it, that theoretically it can be affected because of the voluntary striated muscles used during expulsive efforts may be easily weakened. However, we haven't really seen that happen. Usually it goes uneventfully. If there is any problems, we use instrumental delivery. Appropriate steps should be taken to circumvent the events of maternal fatigue on delivery, since stress and exertion can precipitate a myasthenic crisis. For anesthesia, non-depolarizing muscle relaxant should be avoided in these patients. And all infants with myasthenic mothers should be observed in a special care nursery for the first 48 to 72 hours of life, as transient neonatal myasthenia gravis develops in 10 to 20% of infants due to transplacental passage of IgG acetylcholine receptor antibodies. Okay. Has anybody seen a patient with carpal tunnel syndrome? You've seen it? Never? Okay. Right. Usually patients in pregnancy, they're the same as the non-pregnant population when it comes to carpal tunnel syndrome. The reasons are usually the same, but the good thing is it's usually reversible in these patients. So as soon as pregnancy ends and the edema goes away, usually the patients, they resolve, but they might experience it again in the next subsequent pregnancies. So carpal tunnel syndrome refers to paresthesia, hyposthesia, pain or numbness of the thumb, index, and middle fingers as a result of compression of the median nerve in the carpal tunnel. Affected patients often awake with burning, numbness, and tingling in the median nerve distribution, which is bilateral in 75% of cases. Patients commonly report shaking the hand to relieve the discomfort. Carpal tunnel syndrome is relatively common during pregnancy with an incidence that is wide 2 to 35%. Nerve conduction studies, electromyography are for diagnosis, but we hardly need to use them, okay? Because like I said, it's reversible after delivery. Usually it resolves completely. Patients may receive benefit from splinting the wrist at night in a neutral position or slight extension. So we know it's because of the edema, right? So what we do advise the patient when she sleeps just to raise her arm on a pillow so that the edema will be relieved. Usually in the morning she feels better. Throughout the day she's okay. By the night she starts feeling the tingling sensation and the numbness. Corticosteroid injection or surgery to release the flexor retinaculum is rarely indicated during pregnancy, since the disease has a better prognosis than idiopathic carpal tunnel syndrome and often resolves postpartum. Okay, so surgery, I haven't seen it. Corticosteroid injection, it starts very early in pregnancy, like in the 5th or 6th month, maybe by the third trimester, the late third trimester, she might need the injections, and they relieve it a bit. Bell's palsy, anybody seen Bell's palsy? Okay, so Bell's palsy, like in the regular non-pregnant patient, it's defined as a paralysis of the facial nerve, typically involving all 3 peripheral branches, resulting in asymmetric facial expression and unilateral weakness of eye closure. There is a 2 to 4-fold increase in prevalence during pregnancy, especially in the 3rd trimester or in the 1st postpartum week. The cause for this increased risk of Bell's palsy in pregnancy is unclear. Perineural edema, hypercoagulability, causing thrombosis of the vasa nervosum, and relative immunosuppression in the pregnancy are possible theories. Treatment is like in the non-pregnant patient with corticosteroid. Bell's palsy during pregnancy are the same as for non-pregnant patients. It's not clear whether the risk of recurrence is higher in pregnant versus non-pregnant women, so we don't know if it will occur in the next pregnancy. Okay? Any questions?